Good afternoon, friends. My name is Krasniak Stepan. I'm the researcher in the Department of Andrology and Human Reproduction in the Research Institute of Urology and Interventional Radiology, named after Lopatkin. And I'm greeting you in the breach in the International Urological Projects. We have the following meeting about very interesting topic, I think. It is male infertility. So today, together with our foreign and Russian speakers, we will discuss some different aspects of male infertility, the sexual function, hormonal treatment, and genetic, and so on, so on. I'm proposing to you to ask the question just during the speech. So we will have a question and we'll ask your question to our audience, to our speakers. And one more time, good afternoon, good morning for everybody. So today we have a guest from Italy, from the sunny Italy, and from Rome, together with us, Andrea Sansone, PhD doctor and researcher in the endocrinology and medical sexology at University of Rome, Tor Vergata. Good afternoon, Andrea.
Hi, hello everybody. Dear colleagues, nice to see you again.
Okay, and also we have here Victoria Rosta. She is a PhD student and researcher in the Department of Biochemical, Experimental and Clinical Sciences, Mario Serio, in the University of Florence, also in Italy. Good morning, Victoria.
Hello, good morning, everyone.
And from our side of the boards, the borders at Dr. Shatilka, Taras Shatilka, MD, candidate of medical sciences, urologist in andrology and urology department in the National Medical Research Center for Obstetric Gynecology and Perinatology, named after academician Kulakov in Moscow, Russia. Good afternoon, doctor.
Здравствуйте, buongiorno.
Yeah, buongiorno for everybody. Okay. And we will start right now, and Dr. Andrea will tell us about how fertility results in sexual dysfunction. The stage is yours, Andrea, please.
So thanks again for the invitation. I will talk about what we call the infertile sex syndrome, which is, as you can already guess by the name, the association between the infertility and the sexual dysfunctions occurring in couples with assisted reproduction, but also with other forms of infertility. So just let's go straight to the point. I guess we already know that infertility is quite common in current society. We have, at least in Italy, but worldwide, it's more or less the same definition, which is having at least 1 year of regular and protected intercourse without any reproductive success. We know that the prevalence of this condition is increasing, and it's about to affect 1 in 6 couples, meaning around 15%, which is really high prevalence given whatever we're talking about. More or less, we can consider infertility to have, as many people know, about 1/3 due to male factor only. 1/3 of the cases is actually due to female factor only, whereas about 1/3 of the couples are affected by couple infertility, meaning that there is some male factor and some female factor which are intermingled, having therefore a higher risk of infertility. What we really found as depressing is the fact that 50% of the cases remain unexplained, meaning that we are not able to provide the treatment to these patients. And the only thing that we only can provide is a workaround, meaning assisted reproductive techniques, which, as you know, are actually really a workaround. So we are not solving the issues. We are just mechanically moving the sperm to the oocyte in many cases, meaning that, in fact, if a couple wants another attempt at fertility in the future, this will not be solved by this treatment. Assisted reproductive techniques, as you know, are very different. We have different forms, just like the first line and the second line treatments. So the EUI, meaning the in utero insemination, and the IVF, or the in vitro fertilization. As I was telling you before, we have different forms of infertility. In this Lancet Diabetes Endocrinology paper from 2016, we see that there are quite a few conditions. And since there are that many possible etiologies, there is no actually universally viable treatment, meaning that if a patient has a genetic condition, or if he has an acquired condition, or if he has whatever other conditions, it's not possible to give the same treatment expecting the same results. Luckily for the urology and andrology side, it's quite easier to investigate male fertility rather than female fertility. It's quite easier because, of course, a man just has to provide the semen in order to perform the largest part of the investigations needed. But if we move on to the genetics side, we have to understand that this is quite unknown for both men and women. So new genes are constantly being discovered, as I wrote in the slide. But of course, as long as we just find the genetic reasons, this does not mean that we are finding new treatments, of course, just new causes of infertility. Of course, if we are already visiting a patient with a history of infertility, it's easy to investigate whether he has any so-called risk factors for infertility. So just like smoke, alcohol use, drug abuse, all these conditions are allowed to be treated. And on top of that, if we find that the patient has had a history of a really sedentary lifestyle, or if he has used doping agents, we should also investigate this and treat, if feasible, these health conditions. Just moving to the point, when we're talking about male infertility, we already know that we have two possible treatments, meaning that we have non-hormonal medical treatments and, of course, hormonal treatments of male infertility. Maybe this is quite different from side to side and from country to country, but if you want to go to the point, let's go straight ahead and just say that when we're talking about hormonal treatment of male infertility, which is something which is increasingly being used, at least in Italy and in other countries in Europe, we know that this treatment can only be provided to patients with a well-defined condition, meaning hypogonadotropic hypogonadism. In Italy, we usually define patients which are likely to be treated with this condition with those with lower than 8 FSH values, meaning that patients who have higher than this threshold are usually not suggested this treatment, also because it's quite expensive for the patients themselves, not that much, but actually from the national health system quite a lot. And it's not likely to have any positive results. Then, as I was telling before, we also have this non-hormonal treatment, meaning we can give these patients antioxidant agents. These are actually nutraceutical, so they're not actually real drugs, but on the other hand, these are also not that effective. So we also have to investigate to what extent the patient will be willing to spend a lot of money on a drug which is not known to work in 100% of cases, and which could therefore have no real effect for the patients. So I was telling at the beginning that patients can be suggested assisted reproductive techniques, and this is something that, in our opinion, is quite troublesome because these techniques are often expensive. They're invasive for the couple, even from a psychological point of view, because the patients have to undergo different investigations, from the semen analysis we just mentioned to the ultrasound examinations and so on. And we should also investigate the fact that, highlight the fact that many reproductive health specialists just tell the couples that they should stick to having sex in some very well-defined windows of opportunity, meaning that the gynecologist in many cases just says that if a woman is most fertile around the 14 days of the cycle, this woman should have sex only during that time, which is counterintuitive in the first place, because, of course, limiting the frequency of intercourse is by itself a cause of reduced fertility. And on top of that is something that can violate the patient's intimacy. Also, on top of that, this is something increasingly common, once again, at least in Italy, but I hear from other colleagues in Europe the same thing, that many patients are suggested assisted reproductive techniques since the beginning of their treatment. That's because, as everybody knows, female fecundity decreases over time. So actually starting this treatment at an earlier age might have a more positive effect. But every failed attempt at reproduction has a negative effect on the couple, meaning that the couple has to invest a lot of time and a lot of psychological involvement on the assisted reproductive technique. And then when this fails, it's perceived as a failure for the couple. We also have to look at what evidence provides in this case, and the fact that many people feel that they have to have children, meaning that they have to undergo assisted reproductive techniques, it worsens the psychological status of the couples. And so, what we know for the assisted reproductive techniques, of course, the women have to be investigated quite a lot. So they have to undergo the endocrine assessment of the whole body, but most likely of the pituitary and the ovary. They have to perform ovulation monitoring. They have to perform ultrasound and so on. As I was telling at the beginning, the man usually is easier to investigate because the semen analysis is quite often the most useful analysis for these patients. But of course, in many cases, these individuals might have to go through more complex procedures, just like the testicular extraction. And then, as I was telling before, the intercourse frequency and the timing are also heavily involved in the management of these couples. So the fact that people feel that they have to have sex by the clock is something that has been reported many times in literature, and that has quite a negative effect on the fertility of the couple. And then once again, we were talking about the ovarian stimulation, the testicular examination, and in both cases, this might have potential side effects which are known to occur in quite a lot of individuals. And last but not least, as I've mentioned many times so far, the psychological health of the couple is really, really hit by all these procedures. And it's something that is, in many cases, not that investigated. Why this? That's because despite the fact that most centers having assisted reproductive technique specialists in their centers do have psychological evaluation allowed, the psychologist is not that involved since the beginning, because as you can see here, the psychologist aims to provide support to the couples where they process their grief, where they manage the expectation and the fears for the assisted reproductive techniques. And it's also useful because people can just speak with the psychologist in order to discuss whatever they like without having the fear of hurting their partner. But if you think about it, there's something missing in here. The fact that the couples are not provided psychological support since the beginning. They're just provided psychological support once they start assisted reproductive techniques. And so those who are already in the beginning, at the later stage of treatment, those who have already decided to undergo this treatment, that have already quite invested a lot of time and effort, once again, in assisted reproductive techniques, are those who also might have psychological support, whereas the others are more or less left to their own. This is something that has been quite investigated in the last few years. This is a report from Italy from 2015 on the most important centers for assisted reproductive techniques. And as you can see in here, the prevalence of sexual dysfunctions among couples undergoing assisted reproductive techniques is quite a lot. You can see in here that we have up to 57% of men having erectile dysfunction, something about 25% having premature ejaculation, and around 20% having hypoactive sexual desire disorder. As you can see in women, the situation is quite the same. We have the highest prevalence for hypoactive sexual desire disorder, but we also have lower but still not negligible prevalences of anorgasmia, of vaginismus, and dyspareunia. Hence, based on all this, we investigated this from a top-of-the-view situation, and we proposed the definition of the infertile sex syndrome. What is the definition of the infertile sex syndrome? As you can see in this picture, it's something that involves the couple, so it's not something strictly belonging to the urological or andrological situation, or from the other side of the gynecologist. But it's something that involves the couples as a whole, because it aims to investigate all the different parts of reproduction, so the emotional aspect, the psychological aspect, and of course the organic part of the reproduction as well, and also aims to investigate and treat sexual disorders. Let's go a bit more in detail in this regards. So what happens in a woman who has been diagnosed with infertility? As you can see here, from the psychological point of view, what happens is that in many cases, the woman undergoes this feeling of inadequacy, meaning that she feels like she's not just as cool, just as fine as the other friends. And therefore, she starts also having envy towards their friends. And in many cases, this leads to social isolation. Keep in mind that these two things are also interconnected one to the other, meaning that the more one feels envious towards her friend, the more she feels inadequate. At the end, this, together with the diagnosis of infertility, can increase the rates of depression and anxiety. Of course, this happens more often with the longer duration of infertility. Depression and anxiety are known risk factors for female sexual dysfunction. We already mentioned that before, but just to mention them again, we have hypoactive sexual desire, so meaning that there is less desire to have sex. We have orgasmic dysfunction, meaning that it is more difficult to reach orgasm. And then on the other hand, we also have decreased arousal, meaning that it's also quite more difficult to even get excitement for intercourse. In order to investigate this, we have several questionnaires which are available. We have the FSFI and the orgasmometer. The FSFI, I guess everybody knows it, it's the female sexual function index. So it's a psychometric tool performed to investigate sexual function. Whereas the orgasmometer is like the visual analog scale that is used for pain, but instead of being used for pain, it's an evaluation of the intensity of the orgasm, meaning that the woman can just provide her own perception of orgasm on a scale from 1 to 10. For the man, there is the label in here, shouldn't be here. We have more or less the same thing. Once again, we have the perception of inadequacy and the social isolation and envy, but we also have in the mean the sex by the clock feeling. So once again, the man who feels like he's just a sperm donor, so he just has the role of providing sperm to the couple, feels that he's no longer very virile. And then this leads once again to depression and anxiety, which leads, as previously said, to male sexual dysfunction, like hypoactive sexual desire disorder, erectile dysfunction, and orgasmic dysfunction. As you can see here, we have once again all these questionnaires. The IIEF is the questionnaire for investigating erectile function, both in the 15 items and 5 items version. We have the PEDT, which is the premature ejaculation diagnostic tool, of course, used for premature ejaculation. It goes by itself. And then we have the orgasmometer M, which is just the same as the orgasmometer F, so a 1 to 10 scale, providing intensity of orgasm. Just to mention something in this regard, let's also remember that in many cases, erectile dysfunction and premature ejaculation might be the two sides of the same coin, meaning that the patient starts having premature ejaculation and then this moves to erectile dysfunction, or on the other hand, this could be just like the opposite. And also keep in mind that we're treating couples, not just men or women alone, meaning that we should also investigate the whole part, both part of the couple. If a man has a clinical dysfunction, as you can see here in the slide, this means also that the woman might undergo the same issues. So she might have sexual dysfunction by itself. And once a man with, as you can see here, a clinical dysfunction meets a woman with a subclinical dysfunction, this means, of course, that the intercourse is not satisfactory for both members of the couple. So each treatment in this case is destined to failure. When we look at infertility, we also have to consider that the female factor does not mean that only the woman can develop sexual dysfunction. As I was just saying, we're treating a couple, so male dysfunction might become the source of female dysfunction and vice versa. Psychological distress, as I mentioned many times so far, is closely associated with the status of infertility. And as I was saying before, there is also this feeling of having sex by the clock. Sex by the clock is also associated by the avoidance of intercourse, because couples start feeling that having sex means that they will have expectancy of a pregnancy. Then once their expectation is not confirmed, they decide not to have sex any longer because they won't be sorry, as I wrote in here, because otherwise they will not get pregnant. Also, keep in mind that childlessness is another factor for sexual dysfunction, because people start having what we call couple burnout, meaning one member of the couple blames the other for being the source of infertility. In most part of the world, we know that the female part is largely more investigated, meaning that once a man comes to the andrologist's attention, it's usually after many weeks or many months of female investigation, because there is this cultural bias, meaning that female infertility is considered way more common than it actually is. And so once again, let's go to what happens in the people undergoing assisted reproductive techniques. As you can see here, once this treatment starts, there is the fact that the procedures are very invasive. There is the manipulation with endocrine stimulation. And there is, of course, the weight, which is another source of distress. Everything, once again, can lead to female sexual dysfunction. We already mentioned that before, so just to mention them again, we have hypoactive sexual desire. We have the decrease in intercourse frequency because, as I just mentioned, people start thinking that they should not invest their time in sexual intercourse because it's going to fail. We can have also these other conditions, so coital pain and decreased arousal and satisfaction. For men, it's more or less the same. We already discussed the fact that there is this self-respect of the sperm donor, and everything, once again, leads to the same sexual dysfunctions. So, once again, we have to look at this. We are talking about andrology and urology, so let's focus a bit on the male side. What we know is that up to 1 in 2 men, so 50%, or up to 1 in 6 men, once they are diagnosed with infertility, actually develop sexual dysfunction, meaning either or both premature ejaculation or delay or erectile dysfunction. And when we're talking about sexuality, as I said before, there is this idea that procreation gets completely separated from sexuality, meaning that the couple loses their intimacy. Then once again, treatment failures once again worsen the couple behavior. Once again, infertility worsens the psychological status, and men and women who are more depressed have also a negative effect on fertility. And so we should just stick to the idea that psychological support is actually really needed for these patients. But as I mentioned before, this is quite rare in the real context. We know that some treatments can be proposed, just like sildenafil, which is Viagra, or these drugs being used before semen collection. But once again, if these treatments are given to a patient, it should be extremely clear that they are not treatment for infertility. So they should not be considered as treatment for infertility and should not be proposed as a no-label treatment. Moving ahead, we know that there is this condition, I said before, the infertile sex syndrome. So if we just consider reproductive issues separated from sexual dysfunction, everything is going to fail. The infertility and sexuality should be considered as part of the same single clinical entity, as I wrote in here. And failing to treat the second one ultimately leads to the worsening also of the first one. So treating all infertility without taking into consideration also sexual dysfunction is not a good idea, as I said before. And once again, it's not a good idea to treat just the man or just the female. Everybody should be treated at the same time. Psychosexological support is really, really helpful in these couples, also to improve not only the chances of actually getting the reproduction success, but also to improve the quality of life and sexual health of the couples. However, there is quite a lot of this to say, meaning that we do not actually know who is more likely to be affected by this condition, whether the man or the female. And of course, we do not know what happens in heterologous fertilization, meaning with donation of sperm. So if you want to take a look at the picture, this is the paper we wrote. You can easily download it by scanning the QR code in here. Otherwise, it's an open access on the Journal of Endocrinological Investigation, so you can read it and you're here to comment whatever you like. I will just give a short action on something to consider for the future, because we're talking about COVID-19 in this time and stage. So, of course, the effect of COVID-19 has been quite thoroughly investigated for assisted and non-assisted reproduction, meaning that we investigated quite a lot what happens to sexual health. Reproductive and sexual dysfunctions are known to occur in men. So this is something really important, even because we have an increasingly high request for assisted reproductive techniques in a time where it is more difficult to get access to clinics. So it's something which leads to a delay in treatment. And as we mentioned before, delay in treatment to couples who are already in many cases quite old might also have a negative effect. And so this is something that has been proposed even on a worldwide scale, because it's necessary to move ahead and to provide more support to couples undergoing assisted reproductive techniques, even in hard times just like the ones we've already been through. So the conclusions, I guess I already mentioned quite a lot, the fact that we have to investigate a lot of things. We have to investigate both members of the couple, about the sexual dysfunction and the reproductive dysfunction. We have to provide treatments if needed. We have to provide whatever is necessary to the patient. And once again, we have to remember that sexual dysfunction or sexual health is a large part of overall health. And it's quite stupid to just disregard that. Okay, so I guess I'm done with this. So thank you for your attention, and I will leave you with this last slide, meaning that I wanted to update everybody on the fact that in a few weeks we will have, together with the International Society of Andrology and the European Academy of Andrology, an international symposium actually on this, so on the tips and tricks in the management of couple infertility. It's streamed live, it's free of charge for all members of these societies. So I hope to see you there. Bye.
Thank you very much. I completely agree with you that the psychological and sexual aspects of the infertility is very underestimated by the andrologists and urologists also, because everybody want to, to treat with the drugs, with the IVF and so on, and we have less attention to the sexual and the psychological conditions. So, and in Italy, do the andrologists have some kind of psychological education on that? So, because we don't have enough time for discussing these aspects with the couples, and we don't frequently, we don't have often, such a competence to discuss this correctly. Because if you are not a professional psychologist, you may not have sufficient experience in that, and you can just hurt it. So do you have any additional education on you are referring patients to the psychologist?
We usually refer patients to the psychologist, or rather to the psychosexologist, which is quite a different figure in here, because we are not given any chance to work on that during our residency and so on. But many of my colleagues plan to do that or have already done that, because of course it's something that provides more help to the patient. But it's something that people do on a voluntary basis. So it's something that they do over whatever is necessary.
Mm-hmm. Okay, and we have, I think that Dr. Shatilka wants to say something. Yeah, to add something.
Yes, thank you for a wonderful speech, Dr. Sansone. Well, I have a question. We know that some fertility drugs may cause sexual dysfunction by themselves, and vice versa. Some drugs which are used for treatment of sexual dysfunction may negatively affect sperm quality. How often do you encounter such cases, and what's your tactics regarding such patients?
Well, let's start from the beginning. Some drugs, not all drugs, of course. So if a patient is treated, as many times I've seen in my life, with testosterone because he is hypogonadal, testosterone has a negative effect on spermatogenesis at high dosages. So once again, in this case, the first thing that should be done is, of course, withdrawing this drug and then once again, expecting an improvement over time. If this does not happen, it's time to look for other treatments. So in the case of testosterone, we usually give selective estrogen receptor modulators, which are off-label. So it's something that patients should be aware of, but it's something that can be helpful to treat these patients. On the other hand, drugs used for fertility with a negative effect on sexual health are more common in female, as far as I know, than in men, meaning that giving antioxidants, as I was saying before, or giving FSH to a man does not have really that negative effect. However, of course, there is also the fact that many individuals do not like these drugs, meaning that this can be a source of distress in their own, meaning that this increases, but it's more from a psychological thing than an organic thing finding. I don't know if I answered your question correctly.
Yes, I just wanted to know whether our thoughts are different or the same on this topic. Thank you. I think they're pretty much the same.
And Andrea, you have said that some kind of sexual dysfunction, it's very big a portion of the patients. And do you think this is a de novo situation, or we just reveal those sexual dysfunction what have been started some times ago, or just the infertility problem starts sexual dysfunction, or this just become diagnosed?
Well, let's just say that, as I mentioned before, we often have some these subclinical dysfunctions, meaning that the dysfunction is already present, but it's something that the patient can overwhelm. So let's just make an example. I have seen many patients with diabetes. Diabetes is a known risk factor for sexual dysfunction, of course, who do not develop their sexual dysfunction until they become distressed by infertility, meaning that this is another risk factor which has a multiplicative effect. So it has a negative effect on health, and of course it worsens their sexual health, leading to the onset of an overt dysfunction. So from, as I was saying before, from subclinical to a clinical condition.
Mm-hmm. Okay. And the routine, from the routine practice, the question, what is your opinion about the optimal frequency of the intercourse? What advice you give to your patients about that? It's a very, there's a first question from them.
Yeah, that's quite a difficult answer to give, because of course saying whatever means that then the patient starts coming with more questions on that. So if I say you should have sex every 2 days, 3 days, and so on, this means that of course the woman just starts hitting her partner, says, I said, I told you we have to do that more frequently or less frequently. So it's always a problem with the couples. Mm-hmm. But on top of that, there is no actual idea, meaning that of course if a patient just has sex once, if a couple has sex just once every month in this time of opportunity, it's not gonna be very successful, I guess. If they have sex 12 times a day during their hot days, let's just call them like this, well, the better for them, I guess, but there is no actual proof that they will have better chances at reproduction.
Happy guys.
Yeah, happy guys maybe, or tired guys.
Oh yeah. So okay, we will move far away. So let's continue. And the next speaker is Victoria Rosta, and she will tell us about the genetic aspects of male infertility. Please, Victoria.
Thank you very much. So good morning again. I'm Victoria Rosta from the University of Florence. I would like to thank the invitation for the organizers. And today I'm going to talk about the genetic aspects of male infertility. So why genetics is important in the evaluation of male infertility? Because we can find this in all etiological categories, in hypothalamic pituitary axis disturbances, in spermatogenic quantitative and qualitative disturbances, and in post-testicular ductal obstruction and dysfunction. Due to the sake of time, I'm going to focus on the genetic factors of non-obstructive azoospermia due to primary testicular failure. So the frequency of genetic alterations is significantly increased with the decrease of spermatozoa in the ejaculate. So in oligospermia, these known genetic factors are around 10%, while in azoospermia, these genetic factors, so this risk, so this incidence increased 25%. The most common genetic disorder causing primary testicular failure is the Klinefelter syndrome, which is characterized by an extra X chromosome due to a parental non-disjunction during meiosis. The typical clinical manifestation of the disease is derived from testis dysfunction, from X-linked gene dosage effect, and from the modulatory effect of common polymorphism. Klinefelter syndrome patients are characterized by tall stature, eunocate habitus, long arm span, gynecomastia, central obesity, and small firm testicles. The testicles are usually less than 4 milliliter, and they are firm due to hyalinization and fibrosis. So, and what kind of test we should perform? Simple karyotype analysis, and when we should perform it? According to the European Academy of Andrology and the MQN guideline, we should perform it in azoospermia and in oligozoospermia less than 10 million spermatozoa per ml. But I have to highlight that these patients, so Klinefelter syndrome is not only a problem of fertility and sexual activity. These patients have several comorbidities such as metabolic syndrome, autoimmune diseases, osteoporosis, and have an increased risk to develop neoplasms such as breast cancer, germ cell tumors, and non-Hodgkin lymphoma. So these patients need a lifelong follow-up with a multidisciplinary team, but especially with an andrologist for testosterone replacement therapy. Another karyotype anomaly in azoospermia is the 46XX male syndrome, the so-called De La Chapelle syndrome, which is a rare disease, sex reversal, and the suggested genetic mechanism leading to this disease is the partial translocation of the Y chromosome to the X chromosome, including the SRY gene. And this could cause male sex determination because the SRY gene is the master regulator of testis development. In the minority of cases, so in around 10%, the cause is the duplication of autosomical genes involved in testis determination, such as SOX9 or FGF9 genes. The SRY positive cases, so in around 90%, these patients have normal male phenotype, small testis, and azoospermia, while the SRY negative cases may present with ambiguous genitalia. What kind of test should we perform? We should perform a karyotype analysis, and for the presence or absence, to detect the presence or absence of the SRY gene, we should perform FISH or plus minus PCR. In about 7% of non-obstructive azoospermic patients, the cause of azoospermia is the Y chromosome microdeletion. The origin of this deletion is most likely a meiotic error with the non-allelic homologous recombination mechanism. The clinically relevant classical deletions occur in 5 fragile sites on the long arm of the Y chromosome. So here you can see the Y chromosome. This is the short arm and this is the long arm, and the long arm harbors several genes essential for spermatogenesis. This dashed line shows the region which is missing. So for instance, in complete ACF-A deletion, only these 2 genes are missing. But other complete deletions such as ACF-B or a complete ACF-B or complete ACF-C deletion, much more genes are removed, important for spermatogenesis. The most frequently deleted ACF region is the ACF-C region, which occurs about 65–75% of cases. The clinical significance of these deletions are clear because they have a cause-effect relationship. So the microdeletions originates from the father testis during spermatogenesis, and the frequency of this microdeleted sperm is around 2 sperm in every 100,000 spermatozoa. So if the spermatozoa with the microdeletion fertilize the oocyte, the couple are going to have an offspring who is going to be azoospermic or severe oligoasteroteratospermic in their adulthood. So he will be our patient later and are going to carry this deletion in all of his cells because it is a germline mutation. So there is a kind of genotype-phenotype correlation. So in case of complete ACFA deletion, the testis histology is certainly cell-only syndrome, consequently with azoospermia. In case of complete ACFB deletion, the testis phenotype shows spermatogenic arrest with azoospermia. And in complete ACFC deletion, the testis phenotype varies from hypospermatogenesis to certainly cell-only syndrome. So consequently, the sperm phenotype varies also from azoospermia to oligozoospermia. In case of partial deletions of ACFA and ACFB regions, the testis histology shows hyperspermatogenesis, and the semen phenotype could vary from azoospermia to normozoospermia. So, and how can we test ACF deletions? Diagnostic testing is performed by PCR amplification of selected regions of the Y chromosome. It should be tested in severe spermatogenic impairment, so under 5 million of spermatozoa per ml, according to the European Academy of Andrology and the AMCAN guidelines. This guideline is open access, so everybody can freely download it. But nowadays, genetic testing is changing in the era of next generation sequencing. Analyzing the whole genome or the whole exome became much more rapid and cost-effective. Next generation sequencing in male infertility is continuously growing, and it is a powerful tool to identify novel genetic factors, especially monogenic causes of male infertility. NGS means massive parallel sequencing, so millions of DNA fragments sequenced at the same time. It can be used through gene panel analysis, so which means the sequencing of limited number of genes participating in the same biological pathway. Whole exome sequencing means the analysis of all of the protein coding genes, which are around 20,000. But what are the exons? A gene has exons and introns. Exons are the protein coding regions, and introns are the non-coding regions between exons. Whole exome sequencing is the most widely used method among NGS, and with this method, we are searching for rare and pathogenic mutations. The third method I have to mention is the whole genome sequencing, which is not widely available. And with this method, we can analyze the whole genome, so all of the exons and all of the introns as well. There are several ongoing collaborative projects with exome studies. One is the International Male Infertility Genomics Consortium. This collaboration is between Professor Tütelmann from Germany, Professor Don Conrad from the United States, and Professor Cilla Kraus from Italy and from Spain. I would like to present an example which was recently published by my PI, Professor Cilla Kraus, and colleagues Anthony Riera Escamilla. 17 TESA-negative patients were selected with complete meiotic arrest testis histology. Some of them had family history of infertility and consanguinity. We performed the whole exome sequencing and filtered for rare pathogenic variants. We detected 7 pathogenic already reported NOA genes in 9 patients. So we were able to upgrade their clinical evidence, and they could be included in the diagnostic gene panel. These variants were in genes such as TEX11, TEX14, STEX3, DMRT1, among others. But the most interesting findings of this study were the detection of 5 novel candidate genes with recessive loss of function variants. In order to provide final clinical evidence for our findings, we replicated these mutations or these genes with the help of this collaborative consortium, and immediately 4 out of 5 genes were found in more cohorts of NOAH patients with meiotic arrest testis histology. Thus, these genes were immediately validated. So these genes are ADA2, TERG1, SHOC1, and MSH4. So an important monogenic cause of azoospermia is the deletion of testis-expressed gene 11. This is an X-linked gene, so TEX11, and it was first detected by Yatsenko and colleagues with the method RACGH. It can be found in 0.51% of idiopathic azoospermic patients, and it causes meiotic arrest. So if we carefully select patients, the frequency of the deletion can be much more higher. So the number of candidate genes of azoospermia with clinical evidence and prognostic value is increasing rapidly. The testing of these genes should be carried out with next generation sequencing with diagnostic gene panel analysis. So since the only symptomatic therapy of NOAH is the testicular, so the only effective symptomatic therapy of NOAH is the testicular sperm extraction with intracytoplasmic sperm injection, we should know that the genetic etiology of azoospermia, how can influence the prognosis of TESA. TESA prognosis highly depends on testis phenotypes. So as we all know, in obstructive azoospermia, the spermatogenesis is normal. So sperm retrieval rate is really high, it's around 100%. On the other hand, in non-obstructive azoospermia, if the testis histology shows hyperspermatogenesis, TESA can be successful in 50–60%. In case of Sertoli-Saloni syndrome or in meiotic arrest, TESA outcome is virtually 0. So to date, there are no valid clinical or biochemical parameters to predict TESA outcome. So that's why genetics is important, because so to define the genetic etiology is important, because it can help to decide whether we should perform TESA or not, or how the TESA outcome will be. So in Klinefelter syndrome, even if FSH is high or the testicles are really small, the average sperm retrieval rate is around 34–44%. In case of 46XX male syndrome, TESA is not recommended at all, because important genes for spermatogenesis are missing from the long arm of the Y chromosome. So the chance to find spermatozoa through in the testicles through TESA is virtually 0. In case of ACF deletions, genetic testing is not only diagnostic, but is a unique example for genetic test with prognostic value, because patients carrying complete ACF-A or ACF-B deletions have virtually zero chance to find spermatozoa. In case of a complete ACF-C deletion, these patients have 50% chance to find spermatozoa in their testicles, so ICSI could be or should be carried out. As a conclusion, we can say that the Y chromosome microdeletions testing allows a correct pre-TESA counseling. Complete ACF-C deletion is an interesting one, because 45X0 mosaicisms could occur, so Turner mosaicism could occur, which is a negative predictive value for TESA outcome. The screening for 45X0 cell lines is recommended, and genetics counseling is advised as well. So this was briefly the genetics of non-obstructive azoospermia due to primary testicular failure, and I would like you to thank your precious attention.
Biology. So I have many questions really, okay. And the first, I think the major one is for us, for clinicians, what is from your point of view, the best genetic diagnostic algorithm? So if we have a patient with a non-obstructive azoospermia, what we can do for him to reveal the genetic aspects? From which genetic evaluation we should start, and how we need to move next to the bigger one?
Okay, so actually everything depends on sperm phenotype, I guess, and the phenotype of the patient, so all of the clinical manifestations. So in the ambulatory, we can see the patients who present with azoospermia or severe oligoastenosous
if we are talking about the non-obstructive azoospermia, so we have azoospermic man.
Only azoospermic man, okay. Yeah. So actually, the guideline says that we should perform immediately for azoospermic patients if we find 2 times azoospermia. So one sperm analysis is not enough. We have to perform always 2 times to ensure that our patient is really azoospermic. Then we should start with a karyotype analysis, and then we should continue with the ACF deletion analysis. So obviously we are searching for complete deletions, but partial screening for partial deletions can be performed as well. And in some laboratories, the TEX11 gene is so the detection of the deletion of TEX11 gene is already included in the evaluation of the genetic evaluation of male infertility, but it's not widely spread. So TEX11 it's not done everywhere.
And what about we found nothing there? Should we go to the whole exome sequencing or something like that? And do we need to do this from the clinical point of view? How do you think?
Okay, so in the clinics, we are not performing yet whole exome sequencing because it takes time. So to have the results is much more longer, and maybe if the couple or if our patient is already in the line or in the process of assisted reproductive techniques, they do not have time. So they have to go on, and in the clinic, we only do karyotype analysis and ACF deletion screening, and sometimes TEX11 screening, obviously. But if we have time, we can perform firstly as a research for whole exome sequencing or gene panel analysis, obviously. But as I said, it takes time. It takes several months to get the results. So
several months?
Several months, yes, actually, because we should take the blood, then we should extract DNA from peripheral blood lymphocytes, then we have to do this whole exome sequencing, which takes time. Then we get the results, the bioinformatic have to do his work, and it takes time. And then all of these huge Excel files with lots of the variants arrives to us, and then we have to search for really the damaging and rare mutations which can be the cause of the azoospermia. And it takes time to find these variants, these mutations, because these files are really huge with all of the results. Patients have around 22,000 variants, coding variants. So it's a lot of work.
Okay, what about the more popular, for example, in Russia, genes CFTR and CAG repeats in the androgen receptor? Do you use it in your practice, or is it useful? What do you think?
Yes, actually, I think it's useful. So obviously, to proceeding with assisted reproductive techniques, CF gene, so CFTR gene should be performed previously to do assisted reproductive techniques. And CAG repeats, we do not do it in all of the clinics, but sometimes if our patients have hypotestosteronemia, so hypogonadism, then we can check out for these CAG repeats.
Okay, and one more question for me. Sorry, colleagues, I will give you the word after that. And GWAS study, genome-wide association studies, now become more and more popular, like, consumer genetic, like in 23andMe and other, stuff. So what do you think? Can we have a chance to have some information from there, from these DNA chips? And do we need to recommend these kind of studies to our patients?
Actually, GWAS, so genome-wide association studies, yes, it's recommended, but in azoospermia, so in male infertility, it's difficult to say that this SNP, so this is a common variant, could cause the azoospermia. So actually, we can say that maybe it could be a risk factor for male infertility, but we cannot say that this is the cause of azoospermia. And till now, we didn't find SNP, so this is single nucleotide polymorphism, which was the cause of azoospermia, because they are frequent variations among population.
Okay, thank you. Please, Andrea, have a question.
Okay, sorry. Just a small question, Vicky. What about people with translocations or chromosomal inversions? Because sadly, I'm one of them myself, so I'm already a bit aware of what happens. But of course, if you want to tell us something in this regard, this could be also useful for others.
Yes, of course. Obviously, this kind of translocations, inversions, Robertsonian translocations, and so on, is detected by karyotype analysis. So we should perform a karyotype analysis to confirm this kind of karyotype anomaly. But actually, these type of anomalies are much more frequently found in oligospermia than in azoospermia. Depends on the time, because in inversions and translocations are several types. So obviously it depends which type is it, but we found it much more frequently in oligospermia than in azoospermia. To proceeding assisted reproductive techniques, obviously genetic counseling is advised. So or pre-implantation genetic testing to be much more secure to have a healthy offspring is advised or recommended.
Okay, Dr. Shatilka, please.
Okay, thank you, Dr. Ross. That was a very interesting speech. I have a comment and I have a question. I'll start with a comment, if I may. Okay, in my opinion, those sperm recovery rates, like 50% in Klinefelter syndrome and in AZFC mutations, are a bit optimistic, because in our practice, most patients with Klinefelter syndrome or AZFC mutations who undergo microTZ have zero sperm retrieval chances. Like not entirely zero, of course, but they have lower than 50%, that's for sure. We tried to learn why this happens, why there's such a discrepancy between literature and our results. And we have found that indeed sperm may be found in about 50% of Klinefelter syndrome patients, but they find it on extended sperm search in ejaculate. But of course, we don't perform microTZ in such patients. And this probably explains this discrepancy. That's just my comment. I don't know, maybe you have other knowledge on this topic. And here's my question regarding AZFA and AZFB mutations. It is a rule which is marked in guidelines that we shouldn't perform microTZ in such patients. But if you look at the literature sources, only 14 patients were studied in a study by Hobbs and co-authors, which is referenced in European guidelines. Only 11 patients with AZFB and 3 patients with AZFA. How do you think, is this enough to support this guideline, or maybe we should make exceptions and perform microTZ in patients with AZFA and AZFB mutations?
Now, actually, so if the guidelines said that it was in 2013, obviously from 2013, these cases are much more. So we found much more patients. And I should say that in the case of AZF-A deletion, we are not in complete AZF-A deletion. We are not performing TISA. But in case of AZF-B deletion, if we found it, we have to do an extension analysis. So we are searching for much more primers. And then we can say that if there is a primer, as I showed on the slide, if it's present, then we can do TESA, because there is a chance to find spermatozoa. So if that primer is not present, so there is really that type of complete AZF-B deletion, then we do not recommend TESA to perform. So this is my answer, actually, that depends on the analysis, depends how they do the analysis. So they do the extension analysis as well or not. If they do not perform the extension analysis, then really we cannot say that it's not recommended, or which is zero the chance to find spermatozoa in the testicles. But if they do this extension analysis and we found that there is that the complete deletion is really complete, then we do not recommend TESA.
Thank you. Thank you.
So we need to ask our genetic labs whether it's partial deletion or the complete deletion. So, and from there we need to decide.
Yes.
Okay, thank you very much. If nobody have any other question, we will move next speech, and the Dr. Stilka will tell us about endocrine evaluation and therapy of male infertility, please.
Well, why should we even talk about hormones when talking about male fertility? Why should andrologists even care about endocrinology? Because it's a completely different specialty. Because we work with organs which are partially or completely controlled by hormones. For example, testis is a sex hormone producing gland by itself. Prostate, seminal vesicles, and epididymis are hormone sensitive organs, and bladder and male urethra are potentially hormone-dependent organs. As for penis, it is dependent on hormones during fetal development and in early stages of life and in puberty. But of course, it's also hormone-sensitive organs. Which hormones regulate male reproductive function? Those are testosterone, estradiol, gonadotropins, prolactin, and some hormones which are rarely discussed, such as activins and inhibins and anti-Müllerian hormones. In order to work successfully as a reproductive andrologist, you should understand which hormones play a role in male physiology. You should interpret the endocrine results, and you should be able to interfere with hormone levels successfully to improve patients' chance of conception in a couple. And hormonal regulation of spermatogenesis basically depends on two main hormones, testosterone and follicle-stimulating hormone. Testosterone affects proliferation of pale spermatogonia, and its effect on other steps of spermatogenesis to this day remains controversial. As for follicle-stimulating hormone, it's a main endocrine factor which regulates all steps of spermatogenesis, excluding meiosis. Meiosis remains a mystery because there is no obvious regulator of meiosis. And from a clinical viewpoint, a synergy between testosterone and FSH is necessary to initiate and support spermatogenesis. If we lack testosterone, or if we lack FSH, if we lack something of this, the spermatogenesis will be suboptimal. It may still be existent as, for example, fertile eunuch syndrome or Pascalini syndrome shows us. Spermatogenesis is possible, but it won't be optimal unless FSH and testosterone levels are normal. So why should we evaluate certain hormones? Testosterone, of course, we should evaluate it because it's a possible therapeutic target. As for SHBG and free testosterone, there is a huge, well, I highly doubt it. I highly doubt that we should evaluate, and I will elaborate on this thought later. Estradiol, we should evaluate it because it allows to make an informed decision when choosing between SERMs or clomiphene citrate and aromatase inhibitors, because depending on index of testosterone and estradiol, we may choose one or other type of drug. LH and FSH are possible therapeutic targets, and they really affect management. As for PTH, it's rarely clinically relevant in andrology, except premature ejaculation or delayed ejaculation, but it may be useful for screening of some coexisting conditions. We shouldn't always focus on male sexual organs because a patient may suffer from other conditions as well. Prolactin in itself rarely affects management, but hyperprolactinemia is possible, of course. It may be suspected based on clinical symptoms and altered levels of other hormones, but it may be rational to include it into your basic evaluation in order to avoid repeated numerous blood tests, which may be stressful for the patient. So what would I include into the basic panel of endocrine evaluation? It would be total testosterone, estradiol, gonadotropins, and prolactin. As for SHBG, well, there's a little bit of heresy on my part because I think that free testosterone and SHBG may not always be clinically relevant. In my opinion, in most cases, they are not clinically relevant because SHBG is a transport molecule doing its job. It's not an enemy. And if we talk about fertility, we should be able to assess intratesticular testosterone, which is currently not possible technologically. But judging total testosterone, we may get a hint of what the level of intratesticular testosterone is. Probably if testes produce enough testosterone to share it with the body, they have enough testosterone for themselves, but precise correlation between these parameters is unknown. So SHBG in male infertility plays almost no role. And there is a just discussion whether we should check it at all in sexual dysfunction, for example. On AUA, American Urological Association Congress, I've heard some interesting thoughts about that. And I was happy to hear it because it was my thought for a long time. As for inhibins and activins, it's a group of TGF-like proteins which consist of two dimers from a set of three. Their activity is mediated mainly by autocrine or paracrine mechanisms, and in male, only inhibin B is sufficiently stable to be assessed in a systemic circulation, and it's only inhibin which is sought to possess endocrine activity by itself, not paracrine, but endocrine. FSH activates spermatogonia and initiates spermatogenesis. In turn, spermatogonia and Sertoli cells produce inhibin B, and inhibin B in itself lowers production of gonadotropins in pituitary. Reference values provided by some laboratories in Russia are as follows. They are listed here, generally below 300 picograms per milliliter, which is, of course, a very broad reference range. Probably this range was determined for oncological purposes because elevated inhibin B is typical for granulosa cell tumors of testes and ovaries, and that's how this reference range came to life. But in male infertility, the best reference range would probably be 125 to 215 picograms per milliliter. That would be more accurate. Some doctors actively study inhibin B levels in non-azoospermic patients, but in them, it has almost no diagnostic value unless you screen between, unless you have to choose between obstructive and non-obstructive severe oligozoospermia. In other cases, it's not useful. And despite inhibin B shows some correlation with micro-TZ outcomes in azoospermia, in maturation arrest, for example, it may be normal or even elevated. And on the other hand, if we talk about Sertoli cell syndrome with focal areas of spermatogenesis, inhibin B may be almost zero, but still you may find a solitary sperm on micro-TZ. So the best thing that inhibin B level allows us to perform is an educated guess, basically. What about anti-Mullerian hormone? It plays a very important role during fetal development when sex determination occurs, but physiological role of AMH in adult males remains unclear. In my practice, I usually prescribe this test to azoospermic patients because zero-level AMH may signify total necrosis and sclerosis of seminiferous tubules when even microartesia attempt is not viable in Klinefelter syndrome, for example. If AMH is elevated, well, here's a little trick because we know that testosterone suppresses AMH production in adults. So if a patient has high testosterone and high AMH at the same time, maybe it's an indirect sign of minimal androgen insensitivity syndrome. But there is very little data published on this topic. So basically, those are just my assumptions. What are the possible settings for endocrine treatment in male infertility? Of course, it's hypo or hypogonadotropic hypogonadism, functional hypogonadism together with oligozoospermia, idiopathic oligozoospermia, azospermia, including settings when we need to perform therapy prior to sperm retrieval to increase possible chance of microartesia success. Male infertility together with sexual dysfunction, of course, and that's a little controversial, but very interesting topic about influence of FSH levels on DNA fragmentation index. So, which agents do we use for endocrine treatment? Of course, there are SERMs, or selective estrogen receptor modulators, which are basically clomiphene and tamoxifen. Other SERMs are rarely used in male infertility. Why don't I use the word anti-estrogen? Because mode of action of SERMs is unrelated to the anti-estrogenic properties. There is no good male hormones and bad female hormones. There is no such dichotomy. And clomiphene, for example, has no anti-estrogenic activity by itself. It only acts at the level of hypothalamic pituitary system. Tamoxifen blocks estrogen receptors only in breast tissue. But if we talk about bone tissue, for example, it has agonist properties. So it's not anti-estrogen, it's SERM, selective estrogen receptor modulators. So that's why I urge you to avoid this word. Clomiphene, which we commonly use, is actually a mixture of two isomers. And clomiphene blocks estrogen receptors in central nervous system. And as for zuclomiphene, which is this isomer of clomiphene, its mode of action is currently unknown. It is known that it has elevated half-life when compared to clomiphene, and it may explain some adverse events which commonly happen on clomiphene therapy. As our colleagues already mentioned, I think in Italy it's off-label, but in Russia, clomiphene citrate, luckily for us, has an indication of male infertility, so we may use it legally, and that's of course a bonus for us. When prescribing clomiphene citrate, follow-up is a key. It's not a good idea to prescribe clomiphene citrate and then let nature do its job. You'll have to check for testosterone, LH, and FSH levels because they may change unpredictably, and you'll have to change the dose or change the drug by itself. So what do we know about clomiphene? It has excellent biochemical response. Almost every patient who receives clomiphene has a boost in testosterone levels, sometimes above 50 nanomole per liter if you talk about high doses of clomiphene. As for spermiologic response, it's not so good. About 10 to 15% of patients have paradoxal response to clomiphene, which manifests itself as oligozoospermia on clomiphene. Luckily, it returns to normal after we cancel clomiphene. And as for symptomatic response in hypogonadism, it's usually suboptimal because patients still are tired, they still have sexual dysfunction, etc. For some reason, clomiphene doesn't work for systemic hypogonadism symptoms. Probably it's caused by the fact that it blocks estrogen receptors in central nervous system. So the patient may have good biochemical response, some spermiologic response. He may have acne, elevated body mass, etc. But his brain still acts like it's hypogonadal. Tamoxifen, unlike clomiphene, is a prodrug which has no metabolites with lengthy half-life, which is good when compared to clomiphene. But unluckily for us, tamoxifen is also off-label in Russia. It is mainly used for breast cancer, and because it's off-label, there's less global experience and it's less available literature when compared to clomiphene. So what are the possible applications for SERMs in male infertility? It's stimulation for secretory oligospermia. It's useless to prescribe clomiphene in patients with partial obstruction of ejaculatory ducts, for example. It may be used for neoadjuvant therapy prior to microTZ. It may be used for enhanced reproductive system recovery after anabolic steroid and testosterone use or misuse. Tamoxifen may be used for gynecomastia because it blocks estrogen receptors in breast tissue in men also. And as for treatment of hypogonadism and ejaculatory dysfunction, the data are inconclusive. What are the possible pitfalls of SERM therapy? There is significant risk of paradoxical response, and some doctors actually prescribe SERMs without checking hormone levels prior to it, and they don't tell the patient to check the levels afterwards, which is, in my opinion, a very serious drawback. It's a pitfall which you should avoid. Other pitfall is that patients with psychological symptoms of hypogonadism may have no response, as I already told you about it. There are many underreported adverse events which are not listed in available literature. For example, spermatorrhea. Many patients complain of spermatorrhea when initiating SERM treatment, but I haven't found mentioned literature about that. Gynecomastia and psychological issues. If you look at female menstrual cycle hormone levels, prior to menstruation, estradiol levels are very low, close to zero. And this is what our patients feel. I tell my patient, if you want to feel how your wife feels during her menstruation, try to take clomiphene. That's a joke, of course, but maybe there is some reason behind this joke. And those drugs are not suited for empirical therapy. So literature tells us almost nothing about psychological symptoms on clomiphene, but you check social media. Those are the memes created by patients who take clomiphene. You see that it's not an easy drug. You shouldn't take clomiphene like candy. It's may have serious psychological sequelae after intake. Only literature source which I found on this topic was a case report of clomiphene-associated suicidal behavior in a man treated for hypogonadism. So maybe we're missing something. Maybe we need to talk more about it and discuss this in the literature. As for aromatase inhibitors, their mode of action depends on decreased testosterone to estradiol conversion and decreased androstenedione and dienestrone conversion. So we decrease estradiol and increase androgen levels, and this partially lowers this negative feedback loop, it's like a weak SERM-like effect. And it leads to a shift of balance between 5-alpha reduction and aromatization of testosterone. Steroid aromatase inhibitors, which are sadly not present in Russia today, may have agonistic activity toward androgen receptors. So when to use aromatase inhibitors? It's used for testicular failure with decreased testosterone to estradiol correlation. It may be used in patients with Klinefelter syndrome to prepare them for microTZ, and may be used together with HCG because HCG by itself tends to increase aromatase activity. Talking about dose of aromatase inhibitors, there are some alternative medicine practitioners who think that 1 milligram of anastrozole per day is excessive for a man, but in our practice, 1 milligram per day works perfectly fine. I haven't seen some adverse events or zero estradiol levels. Estradiol levels decrease, but never below the reference range. I have never seen that with 1 milligram per day. So, an important issue: you should always explain mode of action of this drug to the patient, and better yet, explain it to his wife, because it is mainly aromatase inhibitors are mainly used for breast cancer. And I have frequently got phone calls from wives of my patients who have asked me why I have prescribed an oncological drug to their husband. It was difficult to explain, so it's better to explain it from the start. Also, because estradiol is a main steroid hormone which improves bone density, which controls bone density, it is a good idea to check bone density prior to prescription of aromatase inhibitors. If it's already low, possibly you should avoid this type of therapy and prescribe SERM or something else. Dopamine receptor agonists, of course, may be used in infertile men with elevated prolactin levels, but of course, you should know that if prolactin level is below 700 units per liter, it is unlikely that it's a sole and primary reason of infertility in this man. So what do we know? We know that cabergoline works just fine and better than bromkriptin and other types of dopamine receptor agonists. Sometimes it is not enough to take only cabergoline in such patients, and hypogonadism and infertility may persist despite adequate control of prolactin levels. In such cases, some authors advise using clomiphene citrate 50 milligrams per day, but in my opinion, this dose is too high. But the idea is, of course, important. If cabergoline doesn't work by itself, add selective estrogen receptor modulators. As for injection therapy, we have human chorionic gonadotropin, or HCG, which binds to LH receptors, has no direct influence on spermatogenesis, but it improves testosterone production in Leydig cells. In turn, intratesticular testosterone stimulates spermatogenesis. As for pitfalls of HCG therapy, it may induce aromatase activity in Leydig cells, so it may impair balance between estradiol and testosterone. That's why aromatase inhibitors may be co-used together with HCG. And there is also an issue of prolonged treatment with HCG, when prolonged treatment may cause negative feedback loop. You increase testosterone and you decrease FSH by a negative feedback loop. So some patients may have boost in their spermatogenesis, but then they gradually decline even lower than numbers they had initially, almost like testosterone replacement therapy, but like slower in time. And another possible pitfall is production of antibodies to HCG, which is possible and may lead to refractory situations when patient doesn't receive any benefit from HCG. So HCG binds to Leydig cells. They begin their work, say their mitochondria begin shifting cholesterol inside them and begin the process of spermatogenesis. But Leydig cells remain refractory to further stimulation for almost 2 days. A common mistake is when we think that HCG is similar to LH. Well, they have a common alpha subunit, which is like a handle for an instrument, but their beta subunit is different. In HCG, it's longer, and it has different carbohydrate moieties, which means that HCG has half-life of about 24 hours, unlike LH, which has half-life about 20 minutes. So that's why we may use HCG by 2 to 3 times injections per week, unlike LH. LH treatment would be inadequate if we perform injections 2 to 3 times per week. Menopausal gonadotropin is extracted from urine of postmenopausal women. It contains LH and FSH. Today, their activity is very well controlled, but it still may contain HCG, and proportion between these components is variable. So FSH stimulates spermatogenesis, but LH activity is insufficient to stimulate testosterone levels in menopausal gonadotropins, because half-life of LH is only about 20 minutes. If patient receives 2 injections per week, LH activity is insufficient to promote testosterone. But luckily for us, menopausal gonadotropin contains traces of HCG. So most patients have elevation of testosterone levels, nevertheless. But it's not due to LH, but due to HCG. Oh, so that's a June reference of course, this movie is very famous right now. And folitropins, which are commonly used by gynecologists, are rarely used by andrologists. And they're mainly used in hypogonadotropic hypogonadism, and their use for idiopathic male infertility is controversial. Multiple FSH glucoforms are known, and they may have different functions. As for purified folitropin, it has acidic FSH and longer half-life. So it has some benefits when compared to recombinant folitropin. On the other hand, recombinant folitropin has predictable activity because it's produced in laboratory. It's not taken from urine. And there is no theoretical risk of prion contamination. But as far as I know, there was no cases of prion infection with urinary folitropins. I don't know, maybe colleagues know something more about that. Pituitary folitropins were prohibited in 80s because of prion contamination. But as for urinary folitropins, there are no known cases. But it's only a theoretical advantage. Okay, use in male infertility is possible, but evidence is even more scarce than for SERMs. GnRH agonists, to be successfully used for male infertility, they must mimic natural pulse secretion of GnRH, and they require subcutaneous or intravenous pump placement for this purpose, and this treatment remains experimental. Of course, there are other possible applications for GnRH. For example, Foresta and co-authors advised to perform gonadotropic reset using single injection of leuprolide to promote chemical castration, to increase sensitivity of Sertoli cells and spermatogonia to FSH stimulation. And afterwards, they induced spermatogenesis with recombinant FSH and HCG. But the main outcome measure in the study was level of inhibin B level, which is, of course, not the thing which is good for us. We should find sperm in microtesia. We shouldn't elevate inhibin B. So this study remains largely irrelevant. An attempt to repeat this study was performed by Chinese authors in 2018, and judging to their findings, 2 patients had sperm and ejaculate, but there was no control group of adequate kind. Other main criteria of efficacy were inhibin B levels and expression of certain markers of active spermatogenesis, which is also not something we should be proud of. We should find sperm. We shouldn't find markers of spermatogenesis. So as for specific settings for hormone therapies, it is, of course, hypogonadotropic hypogonadism, when we start by improving intratesticular testosterone levels by prescribing HCG, and when testosterone levels in the serum are okay, we add FSH to improve spermatogenesis. Spermatogenesis recovery may take up to 6 to 9 months or even 2 years, which is, of course, very expensive for the patient, and patient should know about that prior to prescribing this therapy. And about 10% of patients lack sperm in ejaculate despite adequate therapy, which patients should also know about. A common mistake when treating hypogonadotropic hypogonadism is prescribing SERMs. Well, prescribing SERMs in true hypo is useless, because in pituitary hypogonadism, there are no gonadotroph cells which are able to respond to SERM stimulation, and there is no negative feedback loop. In hypothalamic hypogonadism, there is no need to remove negative feedback when downstream regulation is disrupted, and when there's no positive stimulating factor. When there's no GnRH in Kallmann syndrome, no use to prescribe SERMs. And in prolactin-associated hypogonadism, GnRH secretion will return to normal after elimination of excess prolactin. Another setting is preparation of patients for non-obstructive azoospermia sperm retrieval. For example, there's a Weil-Cornell approach, which is advocated by Peter Schlegel and his co-authors, which involves lengthy treatment with clomiphene citrate or aromatase inhibitors. And there is an Egyptian protocol, Elminia approach by Hossein and co-authors, which is very delicate in my opinion, and I like it very much and I use it in my practice. A novel setting for hormone therapy in male infertility is increased sperm DNA fragmentation. Why should it even work in this setting? Because FSH, as we know, inhibits apoptosis, and apoptosis of sperm is one possible source of elevated DNA fragmentation index. Also, FSH regulates sperm maturation. Probably it also affects chromatin packaging. And there is also an idea about standalone antioxidant effect of FSH, but actually, personally, I don't believe in that. I believe the first two modes of action are relevant. So a recent meta-analysis by Santi and co-authors revealed slight but a significant decrease in sperm DNA fragmentation on this treatment, but data remain highly heterogeneous. There is no standard approach, no standard dosage, and indications are currently non-standardized as well. So larger and well-planned studies are required. In conclusion, let me make several statements like, first of all, if hypothalamic pituitary gonadal axis is not broken, don't try to fix it. Secondly, spermatogenesis requires both testosterone and FSH, so we should try to improve both those hormone levels. Also, there is no wonder drug for endocrine therapy, but most settings require to achieve at least normal testosterone and FSH. Also, endocrine therapy requires constant monitoring of hormone levels to adjust dose to discontinue or add other medications. So it's very difficult to standardize and very difficult to study in multi-center trials. And all in all, evidence for hormone therapy in male infertility remains quite poor. Thank you for your attention.
For taking your time. So I have several questions about sperm morphology. How this hormonal treatment, the biggest problem in sperm parameters is to increase the sperm morphology, to make it better. So what is the best way if we maybe don't have a very severe hypogonadism, but if we need to stimulate the spermatogenesis in case of teratozoospermia? So what kind of hormonal treatment may be the best? Because for direct stimulation of Sertoli cells, we'll have only FSH. But yes, FSH can is a part of the HCG, is AMCG, and we can use some other drugs for increasing semen parameters. So what kind of the hormonal treatment could be best to increase the sperm morphology?
First of all, I would disagree that poor sperm morphology is a really big problem. As a study by Jason Kovac showed us, successful conception and pregnancy and childbirth are possible even in poor sperm morphology. I don't believe that's a very important factor unless we're talking about globozoospermia, about defects in sperm tail, genetically derived, of course, and 0% sperm morphology. Those are the problems. But most patients with isolated teratozoospermia with good motility and good concentration of sperm, I don't even consider them infertile. So I wouldn't consider this group of patients to be a target for hormone therapy. That's for sure. But globally speaking, if I prescribe hormone therapy to a man with OAT syndrome, oligosteatoteratozoospermia, usually I see some improvement in morphology, like about 1 to 2%. But I think it's really clinically irrelevant.
Okay, Andrea, you have a question?
Yep. So great talk, first of all. So thanks again. I was just wondering, which is your suggested treatment for those patients who have undergone androgen abuse in the past? You mentioned that during your talk. So which is the schedule you use to help them recover from a prolonged time of maybe oxandrolone or even single testosterone abuse?
Okay, thank you for your question. That's a very relevant issue because there are many bodybuilders, et cetera, who try to conceive a child after their career. You see, the first thing they should do is quit cold turkey. Stop all steroids, stop all testosterone, etc. That's a bad thing they can do. In order to generally, after some time, their sperm begin to return to ejaculate, and even some patients may have normal semen parameters 6 months after discontinuation of testosterone. But of course, some people need it quicker, because, for example, of poor ovarian reserve in the spouse, etc., etc., etc. In these cases, I usually start with prescribing SERMs, with clomiphene citrate. But the problem is they already suffer from discontinuation of testosterone. High doses of steroids and testosterone work as a drug. They have poor receptor concentration in their brain. They are depressed. They are passive, etc., etc. So they usually take clomiphene very poorly. They feel lack of energy. So in these cases, I add HCG. HCG is also not a very good option for those patients who try to quit anabolic steroid therapy, but at least HCG improves their testosterone levels and they feel better. SERMs together with HCG. So best of all, discontinue everything. If needed, add SERMs. If patient takes SERMs poorly, add HCG. That's my technique.
And what time we need to wait for if we are expecting the recovery of spermatogenesis in this patient? So if they stop testosterone and other abuse drugs, so 2 months, 3 months, year?
6 months maximum.
6 months.
Usually I advise to perform semen analysis 3 months after discontinuation.
Mm-hmm.
And but at 3 months, it may be so-so. They may return, but concentration may be still lower than expected. So I make conclusions after 6 months of discontinuation.
Mm-hmm. And what about the vitamin D? We have some paper that vitamin D is some kind of hormone-like action. And what about that? Do you use it? Do you measure it in patients with the hypogonadism?
I don't measure vitamin D because, I measured it for some time, but I never found a patient with a good level of vitamin D in their serum. I don't know, maybe in sunny countries like Italy or southern parts of Russia, it's not an issue. But in Moscow, St. Petersburg, and even
even in Moscow,
other towns, yeah, the vitamin D is never enough. So I switched to routinely prescribing vitamin D supplements to such patients. Of course, don't expect miracles, don't expect any wonders from vitamin D supplementation and infertility. But if you may improve something and it won't cost much, why not?
Okay, and
sorry. Even
yes,
in Italy, there is always a lack of vitamin D. Yes,
even if it's so, even if in Italy it's a problem.
Maybe we need a new reference for vitamin D, because if we're even in the sunny country we have low levels, maybe it's enough level.
Yes. Can I have a question?
Yeah.
My question would be that, so do you perform sperm DNA fragmentation in your clinics? If you perform, what kind of method do you use? And what is the cutoff which you take in consideration? Okay.
Of course, we check sperm DNA fragmentation levels. We use Tunnel test.
Okay.
But if a patient arrives from another clinic with halo sperm test, for example, we also accept it. But it's more difficult to judge because we were used to work with Tunnel. And for Tunnel, we use a reference range of 15%. Tunnel above 15%, we consider this abnormal. But if there is no history of miscarriage or ART, of unsuccessful ART attempts, if together with this Tunnel level is between 15 and 30%, we don't usually start to worry.
Okay.
But if it's above 30%, it's a problem for us.
Okay, thank you very much.
And yes, I would like to note that for our audience too, that the new WHO manual to the semen analysis talks about reference values for the DNA fragmentation, also that every laboratory should have their own reference. So there is no any kind of universal reference value for other, like for the concentration, motility, and so on. So regarding the functional analysis, they urge even every lab have and construct their own reference value. So it's very good for you that you have your own reference, so that you are based on. So, and you mentioned, Taras, you mentioned two spermatogenic markers, ZO1 and MVH. What does it, the markers, do you tell us something more about that?
Those are the immune chemistry markers used for pathology studies.
Oh, so it's not a clinical lab.
I don't actually share the enthusiasm of Hugh and co-authors regarding those markers, because I think our main goal is to find sperm and to achieve pregnancy in a husband's, in a patient's spouse, not improving inhibin B levels and not improving pathological immune chemistry markers. So I don't share their enthusiasm.
Okay. And the last question from me, one from your first slide, you told about the real half-life time, and the instruction of use half-life time. So you have some additional pharmacokinetic data. So why you are not agree with the instruction of use for this drug?
Which drug?
Clomiphene, I think.
Clomiphene, yes. Yeah. You see, there is an official data, of course, on data sheet for this drug for its half-life. But you see, it's a mixture of two isomers, cis-clomiphene and trans-clomiphene. Trans-clomiphene is good. Trans-clomiphene is the main acting substance in clomiphene. As for cis-clomiphene, it is currently unknown whether it causes an improvement in sperm parameters or not. It is my hypothesis that cis-clomiphene is responsible for much of the adverse reactions on clomiphene citrate. And there is pharmacokinetic data on trans-clomiphene and cis-clomiphene, and they both differ in their half-life. Cis-clomiphene has a long half-life of about several days or even a week, and N-clomiphene has a relatively smaller half-life. When taken on average, this mixture of cis and trans isomers has this half-life which is mentioned in the data sheet.
So, but anyway, we use the market available drugs, so yeah.
That's not about market availability. You see, this half-life which is mentioned in data sheet is an average between cis isomer and trans isomer, but we're not interested in cis isomer. We're interested in trans isomer. That's the idea.
Okay. Any more questions? So we don't have a question from the audience. So I would like to thank all our speakers, Andrea, Victoria, Taras. Thank you very much for finding the time in the weekend. So thank you very much for a great speech, for the discussion, and good luck.
Thank you. It was a pleasure.
Thank you, you too.
Thanks for the invitation.
Goodbye.
Very much.
Bye.
Bye. Bye.